My name is Teresa Whelan, and I will be the moderator for today's discussion. Before we get to the presentation for today, though, I do have a few housekeeping items I'd like to run through. During the presentation, all participants will be in listen-only mode, so there's no need for you to put your ringer on silent. Also, today's webinar is being recorded, and we will make available on our website by the end of this week. Although lines are muted, we fully encourage you all to ask questions throughout the presentation, and you can do so by submitting your questions within the questions window on the right-hand side of your screen. Simply type your question in the box, click send, and the folks on our team will field those questions and answer them at the end of the hour. If you should encounter any sort of technical difficulties during the webinar today, please also use the questions chat box to submit any sort of technical difficulties that you have, and again, someone on our team will help you through that. So with that, I hope you enjoyed today's presentation, and at this point, I'm happy to introduce our speakers for today, which are David Halm and Teresa Rueckert. Dave is the Chief Evangelist of CO Health Analytics. In his current role, he interacts and engages with clients to solve their business challenges. He enables strategic relationships with key partner companies by understanding their needs based on the changing healthcare landscape. Dave is an internationally recognized expert in the field of consumer engagement through programs such as value-based benefits and employee wellness. He joined CO in 2009 after more than 25 years with Pitney Bowes Corporation, where he was responsible for introducing their leading-edge programs in value-based wellness. Dave has been a visionary at CO and has built CO's leading solutions on behavioral economic applications for many health plans and a technology-enabled solution to engage members based on the gap value and its impact on the avoidable hospital events. Our next speaker is Teresa Rueckert. Teresa is a solution design consultant at CO, and she brings a diverse background in healthcare, including over 15 years in working in healthcare technology, sales support, care management, population health and analytics, education, managed care, medical compliance, and network management. Teresa has been with CO since 2015. In her current role, she engages with customers to demonstrate the value of actionable insights from data to their business. Teresa's past experience also includes working as the Director of Medical Compliance at Sierra Health System, helping organizations in areas of medical compliance with regulations, laws, and accreditation standards. Teresa also worked in delegation oversight with multiple medical groups as a delegation oversight nurse at Prudential Health. Her background includes working with clients in various areas of healthcare spectrum, including health plans, health systems, medical groups, and providers. With that, I'll step aside and turn things over to our first speaker. Go ahead, Dave.
Thank you very much. I think the key in this next 45 minutes is to think through a thesis of, is risk contracts being viewed by the market as something that's of what we call headwinds or tailwinds? So does it enhance revenue or does it take away revenue? So whether you're a physician, whether you're a hospital system, whether you're an ACO, whether you're a life science company, pharmaceutical company, does risk contracts create headwinds or tailwinds for your organizations? And so we've been talking to many of our key stakeholders across the country, and what we see is the development of what we call collaborations. So the first collaboration is around payer, health plan, and provider. And so they're doing this as a way to create what we call tier networks and more focused contracts to create membership growth in those plans. Secondly, we see tremendous growth with health plans and life science companies, and those would be, again, specialty drugs, devices, pharmaceutical companies, and building out outcomes-based contracting. And the third what we call growth in the market is what we call the IDNs, integrated delivery networks, that are beginning to move into risk-bearing contracts with life science companies once again, but we think that's probably 12 months out and beyond. So why is this all occurring? Yeah, even with all the changes in the Trump administration regarding healthcare in terms of some of their key initiatives, what is surviving is risk shifting. So macro, MIFs, ACO, CMS, innovation grants, bundle payments will continue. And then also the life science companies have to show to the plans and to CMS the value of their device, the value of their medications, and the value of their specialty drugs to show, show value in terms of outcomes. So they're both headwinds and they're tailwinds for all of us within the industry. Okay. So as we think of, as the industry thinks about data, everyone is at a different stage of what we call the life cycle of data. So the industry has grown up if you look at the data marts, and this is just a sort of a visualization of how these data sets begin to be developed. So claims includes both medical claims, inpatient, outpatient. It also includes pharmaceutical claims. And then also there's eligibilities. Eligibility files have, members' key information, age, sex, number of dependents. And then there's what we call lab values. And we know that in the labs, there are significant lab tests done both in the hospital setting, but also on an outpatient basis. The question then is, which lab data has value in what we call below in the use cases? Then there's fitness data. So those would be folks with Fitbit, wearables, etc., where they're now monitoring, tracking those daily routines, and then adjust. And then the question becomes: is the value of that data? So it's not only duration of the workout, but also the intensity of the workout. And the data shows that when there's intensity of the workout, it has a significant impact in terms of a positive outcome at the patient level. Then there's drugs, and this is important in that it gives us real-time data, more real-time data, because drug data is compiled on a nightly basis. So getting this on a weekly basis allows us to capture and score information about the patient, particularly around compliance and the impact on star ratings. The other bucket begins to think about is social economic data. So there was a recent study by the Robert Woods Johnson Foundation which talked about that zip code is probably one of the greatest determinants of health status, more so than genetics, more so than other factors such as number of chronic conditions. So socioeconomic data is household data, which has educational levels, income levels, number of dependents, disposable income, and then also how people receive information, but also how people react to certain information. Then there's all these what we call new data sets, which is the EMR world. So the industry has gone through a tremendous explosion of EMR adoption funded by the federal government. But that data set now is ready to be what I call utilized. But there are significant amounts of data in the EMR, and then the key becomes is which data sets have value within the EMR that can easily be utilized to enhance the use case. And then there's all these device data, and we call this the Internet of Things, which is all the new world of data that will be coming in over the next 12 to 18 months. So you can see that in the world of big data, there's lots of what we call headwinds. And the question then becomes is how do we make this what we call fragmented, identify the key data sets that are embedded in each of these data files, and then how do we use the data to create what we call use cases. So the first one that every health plan, Medicare, Medicaid, commercial, also now the large ACOs is, and they're asking, what's the total cost of care by the patient and also by the provider? So how do we understand all the provider utilization that's being prescribed for the patient, and is the patient utilizing it, and is there a view of what we call the total cost of care? So if I'm an individual with 3 chronic conditions, diabetic, hypertensive, and high cholesterol, does that make me a person that could be pre-diabetic? And do I integrate those 3 chronic conditions to identify potential clinical risk, but also financial risk? So why is this important to providers? Is when they go at risk under MACRA for Medicare, they need to begin to understand the patient holistically, but also what other conditions that are impacting them short-term and long-term. Second use case, and these are just the examples that our clients have given us, is what risk will the member have without claims data? So we get a lot of people, not a lot of members join the plan either through the exchange or the employer changes from health plan A to health plan B, or people switch Medicare Advantage plans, or they switch their Medicaid plans in their states. And so when they come to the plan, they now look like they're brand new. There's no claims that they've got. And so there's a risk factor that the plan has to think through. And so the question is then how do we use household level income data or other data sets to create what we call personas in the market? And everyone uses the term personas, but the industry says, well, we understand personas because consumers are consumers. How do we identify personas of people, and then how do we measure the clinical risk and financial risk? So how do you embed in benchmark claims data to personas to look for potential members that will come into the plan, and then how do you line the programs up so that you do it on a preemptive way? Then there's claims data, and the question then is, how does that impact the financial risk of the member, and how does a physician use it? So we talk to physicians. We've got a number of physician groups that we provide services to. And you talk to hospital systems, and you talk about claims data, their eyes glaze over. And they're saying, I know they're talking to me. I think I understand what they're talking about, but claims data to me is administrative data. I use it to file claims. Oh, and by the way, my office manager does all that. I just provide the codes necessary to be paid. But what's the health plan doing with this? So there's a whole educational process that needs to occur between the health plan, also the pharmaceutical company, life science companies, and the member. The fourth item is, can we use these types of analytics to predict people that will be compliant? So using my example of someone having diabetes, hypertension, high cholesterol, they may be diabetic, but will they highly likely be complied with the diabetes regimen provided to me, i.e. the HbA1c test every 6 months, the specialist visit to the specialist, to follow-up visits, to talk to the primary care doc. And so if it takes, Dave Hahn predicts me to be non-compliant, what things can a health plan, what things can the risk-bearing entity use to engage Dave in compliance? And the fifth item then is okay, we got all this lab data coming in. I've got my HbA1c, it's got my fasting sugar level test, I'm a diabetic. How does this really enhance the prediction of the patient? And how does it how do we use clinical insights now to drive financial risk? And is there value? And lab data is invaluable because it can come on a daily basis, and the feeds can come on a daily basis from the large lab companies that are out there. 6 is the EMR, and it's saying to these various vendors who have the EMRs, which they tend to be proprietary, is how do we capture the value of the EMR data? We know that there's value in some of the data sets that are more valuable than others. Then how do we capture the physician's notes saying, I don't believe Dave is a diabetic, so I want to see him 30 days from now because he's likely to be non-compliant. Then how do I engage Dave in the process or Dave's caregiver in the process over the next 30 plus days? And then 7 is these new data sets. So it's things like weather patterns. It's things like gross domestic product, the economy. How can they be utilized to understand compliance? Because when you have bad weather, does it enhance compliance or does it damper compliance? So we spent some time with a client down south that was hit with a hurricane, and their assumption was, that after the hurricane that there would be increased claim costs, but in reality, there was decreased claim costs because people were dealing with the fundamentals of the damage due to the hurricane. So you deal with, Maslow's theory of hierarchy. And then 8 is, okay, now all this data comes in. How often should be updated? So every customer, particularly providers, have said to us, we want to get data on a real-time basis. And the answer is okay. It's probably very expensive. And then 2 is, what would you do with that data? Does the data change on a daily basis versus a weekly versus a monthly? So there's an equation around value versus time. And then can a data be taught to be intuitive? Can it go through machine learning? Because what you want to do is reduce the false positives, so it predicts Dave to be non-compliant, but in reality, he is going to be compliant because he's got, for example, high compliance levels already for cholesterol, and he therefore will be highly compliant for diabetes, and he might even have a high FICO score. Okay. So we next talk about data layering. And this is an illustrative way of thinking about it, is how do you sequence the data? So it's behavioral attitudes about their disease. It's about the demographics, their age, their relationship with the physician, either primary care or specialist. What are the clinical conditions? What's the impact on quality? Are there adverse events such as ER visits, high-tech imaging, utilization, inpatient utilization, extended length of stay, and then you look at overall utilization. And a lot of the underwriters have said, well, when someone's using a lot of drugs or they're using a lot of office visits, we think that's bad. But in reality, that's actually a good side because then you want to qualify the utilization as a function of what services will be that can be used to improve the health status, and that gets into risk. So data layering is an art form of sequencing of data, and then enhancing data views to predict outcomes at the patient level and the provider. And we believe this would be the next generation of analytics. Stacia, do you want me to ask this question?
Sure. If you want to pose the question, and then we'll open it up for selection.
So this is like quick polls. And the first question is, who uses the following data sets? Claims only, claims and social economic, that's household level, claims, social economic, and EMR data, any format. And last is all the above, plus wearables and other data sets that we may not be thinking of. So it could be CDC data, could be other government types of databases. So if you can answer it, we'll poll it.
And we leave the poll open for about 30 seconds.
So this is like Jeopardy. 30 seconds to...
We should have played the Jeopardy music.
I know. So, thank you, Stacia. So now I'm going to bring you through, what the market has been telling us. Again, this is always about the market. Is okay. Let's begin to think about what we call data layering. Let's look at patient risk without claims data. So can we capture eligibility files, household level? And what we've learned is in a lot of the household level income data, there's missing data files. So what the industry says is, how do we solve for that when it's missing income levels? So, what we've thought through, and in fact, what our scientists have said to us internally is, you can use 9-digit zip code, which is census data, crosswalk the data files that are missing, to populate, those data files that are missing to create enhancements of the data. That works beautifully in probably about 97% of the U.S. It falls apart a little bit in cities like San Francisco or New York City, where a 4-block radius, could have wide variations in income levels. And then how do we look at all of this data to predict probabilities of people to have a disease? And then how do we then create prescriptive? What services should a health plan provide? Should they pre-enroll them into a diabetes program? Should they pre-enroll them in a nutrition program? Should a physician have someone call them on a periodic basis to ask them how they're doing in their regimen of managing their weight or their nutrition? So the bottom 4 are sort of graphically of, there's value in data. You can use benchmark claims data to populate, the household level income data, like an Axiom, KBM, are 2 examples databases. You can then look at clinical risk and financial risk that are prospective. Again, this is, a difference in the marketplace, which is, tell me whether Dave going forward is going to be compliant, non-compliant, so I can engage him. And how do we begin to use these sets of tools to measure provider performance? Are there outcomes from it? Are there ways in which we can use clinical pathways to reduce variations in practice patterns? And that's initially through education with providers. And then having the patient having the ability to see their own data and download their data, to their smart devices to keep it and store it and use it to create what I call the educational process. So this is an example of some personas, and this is this broad, and these are broad, and to your left you got the healthy, affluent, you got the balanced adults, high utilizers, quality-driven folks that are, very, very focused on improving their health status. And so in our family, that'll be my wife, because she handles our children, and she's always driven on quality. Cost-conscious people are very, very focused on cost. Those are folks that may be in high-deductible plans, which there are significant amounts of today. Older chronics, and then high-cost baby boomers. And so you look at, the body list, number of chronic conditions, inpatient ER utilization. And what was surprising in the data, using benchmark databases, was that the young healthy had a higher utilization of the emergency room than what we thought. We thought, that all the green circles would be less than everything else. And when we got into it, we realized that in terms of the diagnosis codes, that significant amounts of these ER visits were driven by accidents, injuries, and falls. So these are very active folks, typically on weekends, biking, running, walking, and doing all types of exercises where there's a propensity for injuries. That's leading to the ER utilization. So we said to a couple of the plans, you might want to educate people that they can use telemedicine for the ER, or they can use a walk-in clinic not affiliated with a hospital, and these are 3 in your area or zip code, and you can put them on your phone so that you can be directed to the right facility. So this is done as applying it. So what do I do? And so we begin looking at these samples. You can begin aligning programs that a health plan, either commercial, Medicaid, Medicare, or a physician group, to those individuals within those, knowing that there'll be some false positives, but it's a preemptive way to say, hey, we think as a balance adult, program number 1 or 3, I'll make it up, it could be nutrition counseling, it could be exercise, would be of high value to those members. So this is a more of a pictorial, and you see up here, it's got the map of the U.S. We had our customers have said, okay, I get these personas, but tell me, where are they? So break it down by zip code or MSA, if need be, if I'm geographically dispersed. But tell me a little bit about them. Tell me their demographics. Tell me, their gender, educational, median home value, socioeconomic status, estimated income, spending patterns, and age groups. And then what types of utilizations, do they have? So this gives you then a snapshot of that member before they've had a claim, because they're new. And we know that if you enroll them in a program, yes, there'll be some false positives, but you can enroll them via on their websites, which has a low cost way of engaging the member. And that's on the assumption that it's easy to find the websites on a lot of the plans, but I think they're getting much, much better in understanding, the consumer and how they navigate the system. So this is additional data sets, and the reason why we like this a lot is this takes in data from the federal government and breaks it down by geographic areas. This is by towns, and this happens to be in Chicago. What this begins to tell you is by area, looks at low birth weights, prenatal care, teen birth rates. You can see Avalon Park, high teen rates, below poverty, high school education, per capita income is lower, unemployment is higher. So when a member comes from these geographic areas or these towns, there's a probability that they'll have some propensities in these types of risk factors, and then therefore you can align your program. So it's an illustrative example of how to think about using outside data sets. So, we start thinking about new data, and we selected, this form of enhancements. And the question, a lot of customers ask us is, okay, I get all this stuff, it's in my data warehouse. What do I use it for? Is there ways for us to reduce avoidable inpatient, avoidable ER visits? Because we know that those are controllable. Can it reduce extended length of stay? Because I'm at risk for it. Is there ways for me to reduce readmissions, particularly if the member is in a CMS program? Is there excessive testing and specialist care? And it begins to look at, is there at the patient level improved predictions? Can you enhance the predictive value? And everyone has predictive models. But how do you really fine tune it to adjust for clinical risk? Then how do you recommend to the physician or the hospital system that's managing the risk at ACO what you should be doing or recommending for the patient? So could you, the thesis there is by creating what we call care pathways, you can reduce the variation in practice patterns from physician to physician, and then you can score those over time to improve the quality of healthcare delivery within a specific geographic area. So, the market, and this is comes from one of our clients, is how do we identify people that are risky, so high impact, then how do I risk stratify them additionally? So those would be high impact, those would be moderate impact, would be low risk. So if T and I were both high impact members, so we have a number of care gaps, and we have a number of care gaps. I've got 7 care gaps. T's got 3. So therefore, I should be re-stratified again to be higher risk than T, who's in the moderate risk bucket. So there's additional tiering as a function of the care gaps, and allows the health plan, health system to steer members to specific networks. So this is an example of an output. This is member 1, member 2, member 3. One's got a 93% probability of being admitted into the emergency room in the next 12 months. And what we've done is said, okay, we get that. Let's enhance the historical predictive values to create an impactability value, and then use that impactability score, which is based on clinical care gaps, to adjust the member's risk, but then to be more prescriptive to the physician to say which care gap to close. So what happens is, when I get a call from a care manager and I've got 7 care gaps, they tell me I've got to do 7 things, I, A, will not remember it. B, I could be driving. Or C, I could be eating dinner or just finishing dinner, and I'm not going to remember. So what 1 or 2 things do you want to leave the patient, the member, that's critical? And so this is a methodology that can be used, and we think that this would be the new forefront of predictive and prescriptive modeling. So poll question number 2 is, in your opinion, so there's opinion now, do additional data sets available at the point of care add value to which of the following? So it's prioritization now. Patients, A. B, providers. C, ACOs. D, health plans, or all the above. So do additional data sets at the point of care. So now it's a point of care with the provider. Is there real value in this?
And we'll just take a few seconds to let the results come in, Dave, and they'll display. They should display right on your screen.
Okay, thank you. Okay. So next I'm going to provide a switch over to T. And the reason why I think this is important is T has a background, she's clinical, unlike myself, but B is she's been with clients historically over the last probably 25 years, large, medium-sized clients, and particularly with all of our clients, we've got about 90 of them, where she spends time understanding their environment, what's needed, and what's the use case of how to use analytics. Because everyone has data, everyone has analytics, but how do you deploy it to create an outcome either at the patient level or provider level? Okay.
Thank you. Hi, everybody. It's T. Rueckert. Dave has been talking about using data to best identify how to engage with patients and members to have a positive impact. And as my screen begins to change, as we look at examples of outputs using technology, I'd like you to begin to imagine if you could use data not only to identify patients and members that are at high risk for future high costs, but could use data to really be proactive, specifically to identify those patients and members where you have the potential to have actual impact. This is an example of how that can be done by using data analysis to identify and focus on patients and members that have chronic conditions where there are gaps in care that result in high inpatient and ED probability And analytics show that by closing those gaps, there is potential financial savings and reduction in ED and inpatient stays. In other words, how to focus on those that have high impactability. For example, here we can see the patients and members with high financial risk and high impactability. For example, here they have a potential savings of over $1 million when we look specifically at those with high impactability and high financial risk. So as we drill down to those specific patients and members that have that high impactability and high financial risk, I now want you to imagine knowing not only necessarily the who to focus on, but as we move to the next screen, having prescriptive insight into what specific actions need to be done. In other words, which gaps to close and the impact that they have on savings. I'm going to move my screen here a sec. And as we look at this, again, looking at the specific patients, looking at the specific gaps, and the actual savings and impact on that. And so why is this so important? Based upon my experiences in working with different organizations and my experience in working as a nurse, most of today's solutions miss insight to help in managing people with emerging high risk. And when we do identify them, it lacks what a care manager should do. So when I'm talking with a patient, to be able to have insight to help me prioritize specifically what gaps to close. And they also lack consistency of messaging to manage those patients and members. So that's why it's so important to be able to have these types of outputs, to be able to get down to that level to understand not only the who or which patients you can have the highest impactability on, but what you need to do and what that impact is onto the savings. So as we're going to move and focus a little bit differently now on the next screen. As I move to the next screen, we've been looking at it from a member-patient perspective. But another example in the use of prescriptive analytics is in program development. We were just looking at impactability at that individual member-patient level, but if we step back and look at impactability now at a condition level, we can see that if you have insight into not only what conditions are costing the most, but what conditions have high impactable patients and members, now you can have insight in which programs to focus on in development. So for example, we can see here that under high impactability bucket, it's diabetes right here. That is the condition that's associated with most of the cost, the highest percentage of cost. So it gives you an area of where to focus your program development. And as I move on to the last slide that I'm going to be talking about, I also want to talk about the fact that, I talk with a lot of organizations and many of them struggle with limited resources. How do we focus those limited resources to have the biggest impact? So prescriptive data analytics can be used to help you focus your resources, for example, in letting you know where specifically to focus outreach. So what I mean by that is not only the what specific gaps you want to focus on, but who are those specific patients and members with those specific gaps, so that by focusing your resources to help close those gaps, you can have the biggest impact where you have the biggest savings potential, where the biggest savings opportunity lies. Before I turn it back over to Dave, I just wanted to say, I hope that these visualization examples showed you really how powerful it can be using data analytics to focus your engagement with patients and members in a way that can help you be successful in your risk-bearing contracts. Thank you. I'll turn it back over to Dave at this point. He's going to go through, I think, a couple of case studies.
Sure. So this is a view of how do you think about the epidemic around opiates, and how does it impact the total cost of care, which is where the industry is going today? And then two is, how do we identify folks that are untreated that should be treated? So those would be all the pre-diabetics, or those would be the diabetics that don't believe they're diabetics for a number of different reasons. And so how do we engage them? How do we drive compliance, or what we call persistency? So the first one is we took a sample of our database, and we said, something's going on with opiates utilization from the media. Tremendous media traction. A lot of states are wrestling with this. And we said, let's just look at a sample database of about 700,000 people. And so let's make it simple. Let's look at all the patients that are using a medication that's used to get people off of a opiate type of medication. So it's prescription used to get people off of Vicodin or drugs like those. And so we identified what we call general risk of the whole population, all 700,000 people, to be 1. And then we looked at the financial risk associated with those opiate users, and it was almost double. So the average spend rate is $5,000 for an individual. The opiate user would have about $10,000 to spend, driven by additional services. And we said, okay, now we get that, but let's just now look at how do we tag on the total cost of care, and let's look at the most prevalent conditions associated with those members. So now we take the member, the NDC code for that drug, NDC codes for that drug. Then we look for the diagnosis codes for behavioral health, depression, back pain, hypertension, asthma, cardiovascular, hepatitis C, eye disorder, ear disorder, and diabetes. If you go to the far right, it was actually very surprising. These individuals that were diabetic, and there was 500 of them out of 700,000 people that were on this opiate type of medication utilization, and they had a risk score of 5, which meant that they had 5 times more cost on average than the average person in the database, sample database. So what we also did with that was, since there were 500, we knew where they lived, so we tagged it to a zip code. We also tagged it to a physician, and so we then created what we call hotspot trending, which is like Doppler radar. It can identify all those patients, track the patients over a period of time to see whether their risk is going up from 5 to 6 or 5 to 7 or going from 5 to 4 as a way to understand engagement with providers. So the total cost of care was very significant, and what it basically said from our medical director, Kevin Keck, was you need to treat the opiate use first, then you treat the chronic condition second to get the person off of their dependencies. Last one is this is a focus around the thesis of, is there a behavioral economics model that can measure the value of the reduction in the patient or the member's out-of-pocket expense? So it could be lower co-payments, which is what CMS is now experimenting with in 10 states under the VBID pilots. And then how do you earmark the incentives? And this could be even companies' wellness and employers' wellness incentive to a disease, and within the disease to a specific service. And then is there an enhancement to improvement of the compliance? So the first one would be is flu shots. Baseline 10.7%. there's 1,492 members, and the model had a low co-payment incentive that was devised, where there was a improvement to 12%. So what this does is it measures the elasticity of service as a function of a member's out-of-pocket expense. Therefore, it has an impact on compliance. And so, in summary, we think that these two worlds are now emerging. So the world of claims, historical, plus some zip code data, and understanding provider utilization, tagged to other data sets, you can create a view of the patient that's really quite different. So, we know that there's going to be significant amounts of rain over the next 30 days. That has a material impact on people's wellness outlook. So there are ways to engage the patient during those periods of time to take the medications. When there's a downturn in the economy, is there ways for the patient to continue their medications using other lower cost medications? So the world of the ability to consume at the patient level, the ability to do it, can I do it, impacts all risk entities, whether you're, again, a health plan that owns the risk, or whether you're the life science companies that's merging into the risk, or whether you're the provider groups or ACOs. So hopefully, we've taken you through a journey of what we call data layering, how to use different data sets with no data to some claims data to other data sets. How do you create value from those for both the patient and the provider? T talked a little bit about some sample outputs, but then it's the challenge of how do you begin to use all this information on a more real-time basis, could be weekly, to drive patient or member engagement or caregiver engagement, which is important. So questions, I think we have polling, and we also have a website that you can log into and see more information or even use cases from our company.
Thank you, Dave. So just a reminder to all, if you would like to ask a question, you can enter it into the questions window over on the right-hand side of your screen. And Dave, we have had a couple questions come in, so we can start with those first. So the first question here is, do you think technology is keeping up with the needs of healthcare?
Yeah, it's a great question of technology. So the technology today is not keeping up with healthcare because it's highly fragmented. So whether you define technology to be an EMR, which is a lot of hospital systems define it, those data sets are difficult to capture and they're proprietary. Two is a lot of this wearable information, Fitbit, Apple Watches, etc., has that data get uploaded and fed into an engine who manages that engine and who produces the outputs. And so we think that the world of technology will get there over time, but still highly siloed depending on who the provider services are. But I would say, though, that talking to a number of large technology companies over the last week when we were in California for a bunch of meetings with some of the greatest, some of the big thought leaders in healthcare, was that technology will begin to evolve and begin to focus on the patient and provider so that more real-time analytics can be utilized and be distributed in a cost-effective way. Again, that's the key, is cost-effectively. But there are a lot of companies that are building these databases now on their specific thesis.
Okay, thanks, Dave. Another question here is focused around resource availability. So are you finding that organizations who need to use data in analytics like you described, do they have the resources and the skills that are needed?
It's another great question. Usually I say it's a great question is there's an acute shortage of data scientists in the country. And so, you know, if you think about it, if I'm 23 years old, I'm out of school, do I go work for health plan X, not for profit, or do I go work for Airbnb, Uber, or Google? And so, you know, the new world, new technologies are drawing talent away from what I call the traditional base. So there's a scarcity of data scientists. There's also a scarcity of people that understand how to clean data, how to cleanse data, how to verify data, reconcile data, and then how to identify the use case of what it means to a plan. So there's still a shortage, and it's global. And so, you know, what companies are beginning to do, it's not only SEAL, but other companies are looking at worldwide resources. So those are resources in China, India, Eastern Europe, South America, where they may not know a lot about U.S. healthcare system, but they're outstanding in the world of data because they've been trained well by all the technical schools. So then the challenge is, how do you then merge the world of U.S. healthcare knowledge to the new world of folks that are really just coming up to create a combined set of assets to bring to the market? So we see a lot of companies do what we call co-sourcing, which is, you know, we want to work with you, but we want to work with you or work with companies like you by using your global resources because A, it's a little less expensive, but B, you know, they're more abundant.
Okay, thanks, Dave. And I've got one more question here for you.
Sure.
So you've talked a lot about these new and different data types, but organizations are challenged with access to data. So can you provide any sort of insight into how organizations are overcoming their access challenges?
Yeah, it's another great question. And so, for example, in companies like ours and all of our competitors, we do not see the person's names. The data files come to us de-identified. And so we have to create a series of what I call locks or keys to reconnect the individual at the claims level with other data sets. So once we identify the key, we can integrate the data and then send back the de-identified information back to the risk-bearing entity. It could go back to pharma if they're the payer, or the health plan, or the ACO, the provider group. It goes back to them de-identified, and then they have to then reconvert it to an identified patient or member to engage those individuals.
Okay, thank you, Dave. Great insight, great content today, both Dave and T. I don't have any more questions in the queue, so I think we could probably conclude for today. So I'd like to thank everyone who joined us for taking time to meet with us. If you have any questions or if you would like to be contacted by anyone at CO, you can visit our website that's on the screen right now, cohealthanalytics.com, and simply select Contact Us. So as a reminder, today's session was recorded, and so as I mentioned at the beginning of the call, we will be in contact with you and we'll make the direct link available to you in the next couple of days here. So this concludes today's conference. Thank you all for your participation and have a wonderful day.